Hey, Dr. Goel, we are with you. In the interest of time, I'll just let you go ahead and present the case. Thanks.
Yeah. Okay. 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 Good afternoon, Arun.
Good afternoon.
Can you hear me?
Yeah, we can hear you loud and clear. We have a great panel here. Surya is also here.
Okay. Yes.
Good afternoon, Dr. Goel, Dr.
Okay,
Rao
great.
here.
So,
please introduce your case.
So, yeah, actually, I'll just introduce my co-operators. Dr. Danish is on my right. Hello. And Dr. Vaibhav, two consultants with us, and Mr. Iqbal is our chief technician, and Virender and Sagar, and nursing Archana. So I'll just tell you the case. Actually, Danish, if you can just speak what the case was about.
So we have a 37-year young male with us.
Can you
with a risk factor of dyslipidemia. His triglycerides were high, more than 500, and LDL was 120 milligram per deciliters. He complained of effort angina for last 2 years. There was no history of any rest pain. ECG was normal, and echo showed the preserved LV function with no RWMA. The patient got CT coronary angiogram done elsewhere, which showed some LAD and RCA disease, and he was taken up for angiogram following that.
Okay, I'll just show you the angiogram. This is the picture. I don't know whether you can see our reporting system. So we have a blocked LAD and a RCA here. I'll show you the angiogram. So that's the aleocranial view as you see. We have the LAD which is totally blocked for its proximal part. The circumflex actually is dominant if you see.
So
next view please. Okay. So the circumflex gives rise to PD, and from the PD you have collaterals to the distal LAD. As you see the septals seen as collaterals. Next. That's the epicaudal view. RAO caudal, again you see some in-between segment which is not filled. Next. So the septals are giving collaterals to the distal LAD. Next. So that's the CTO actually has a tapered tip, so that's a good thing. Next. And that's the right coronary. So right coronary through a conus branch is also giving collaterals to the mid part of some part in the LAD, and the RCA in itself is totally blocked. So I would just ask you what you would think about this case, and so then I'll tell you what.
Middle AD taper
okay?
tip. Middle AD taper tip, only the left dominant circulation in this case. And I think still you can have a in cranial view, it looks like a long segment, but looks like some channel for us. Yeah. So I think antegrade approach with a microcatheter with a polymer jacket wire is the first choice to try.
Again, I don't know what Dr. Goel has done at this point, but for those people that are relatively new, it's absolutely imperative you get bilateral access here. I would still very strongly recommend, you might, if you end up, I would use another guide. Ping pong guides, put a microcatheter, make sure you visualize it. But it looks like it should be fairly, it's a tapered tip, not too long. No, I can't see too much calcium, at least angiographically, and I think the calcium score was also on the lower side. So hopefully it's an antegrade wire escalation case, but you have a lot of options. You have AWE, ADR, retrograde, the whole shebang.
Yes. Actually, I totally agree with you. There has to be contralateral access, so that's what we have planned, we have done. Because the collaterals are coming from the right, so, but I'm sure these collaterals cannot be used for retrograde tracking. So I would choose a diagnostic catheter on the right so that we are smaller, we don't have bigger systems inside. And for the left, we have a guiding catheter. I have two accesses. The hand radial, I usually do the main vessel through the radial. So radial has a glide sheath and CTO has a 7 French guide. So we have a 7 French guide here. And through the groin, right now we have a 6 French system because we are only contemplating on the right side as of now diagnostic catheter.
If you have the ipsilateral,
although it looks like a tapered tip.
Dr. Goel, if you have a ipsilateral collateral filling the LAD sufficiently, and if you are not trying any retrograde procedure to the conus artery, what is the need for the right coronary injection?
Yes. No, that is what I wanted to bring out. The thing is, you know, when you are working on these CTOs, CTO is a CTO. Sometimes you start reducing the flow through one source, and then there is a problem. And the other thing is, the in-between segment, if you see the angiogram well, the in-between segment actually fills through the right collateral only. So now we'll show a bilateral injection, which we have just done.
Sure.
So now you'll see that. Can we see the bilateral injection? Start, please. So okay, that was the hooking. Go ahead. So you know, the guide went into the circumflex. So then it's like a separate orifice. So we chose EBU 3 to get into the LAD, because otherwise with EBU 3.5 we were not even entering the LAD. So next. So we changed to EBU 3, and this is the contralateral injection. Now you see it much better.
Yep.
Now you see the real blocked part, which is about 15 mm or something.
You can target the distal cap
because
better
this in-between part was not seen. Yes, you see the distal cap better. So always, that's why I teach that you should always have a contralateral injection whenever you're doing CTOs. Next. And that's the other view, although the first view, cranial view, was good enough, but 2 contralateral views. Next, orthogonal viewing. So with that, as you said, so here my thought will be antegrade. Hopefully we should cross. Not a very difficult CTO as it looks like. But in case you get subintimal, then maybe parallel wire, or else we can think of ADR. So that's the plan. So I have taken a microcatheter and a Sion wire to get the microcatheter in place. And I think my first wire that I will use will be a XT. So
are you going to
just put the Sion.
Do you have a Corsair Pro? Is that what you have? What microcatheter are you using?
No, this is a Caravel.
It's a Caravel. Why did you choose a Caravel, Dr.
This
Goel?
is a Caravel. You see, I usually used for antegrade a fine cross.
Sure.
Right, but of late I am finding that the Caravel has maybe a little better trackability. And the Corsair makes it everything radio opaque, because the Corsair is radio opaque all through, as you know, the distal 20 centimeters. So visibility is not as good. So I feel for antegrades, the Caravel or fine cross may be fine.
How do you feel Corsair Pro?
So I just used a Caravel.
I mean, like,
for discussion sake.
We're just going to discuss.
I have not used specifically a Corsair Pro.
Each one of these catheters have strengths and weaknesses, as you know, right? I mean, if you are going to go with something that needs...
Because Caravel actually is better than Corsair.
In terms of visibility, yeah, that might be true.
इसको 16 पे करना जरा. Okay.
And the wire that you have chosen, is it an XT, XTR, or XTA? What wire have you chosen, Dr. Goel?
This is XT. This is XT.
So you're just sticking to the XT. All right,
Give me a right injection, please. Yeah, yeah. I usually use XT as my first choice.
Okay.
Right injection, please. Okay.
We'll just stay with Dr. Goel for an additional minute because we started a little bit later, and then we'll go to Dr. Werner's lab. Dr. Goel, we're going to stay with you for another minute or so, and then we're going to switch to the other lab, and then we'll be back.
Okay, okay. Okay.
Do you want to like tell the audience like what are you doing with your fingers? Like, you know, just talk tell them in terms of how are you manipulating this wire?
Focus it? I don't
can
know.
someone just focus, please?
Someone can
Thanks.
focus it.
Yeah. So it's kind of a controlled drilling that you're doing?
I think I've done it. Yeah, actually what I do, what I'll tell you about XT, I'm a fan of XT. I don't use XTR. XTR has to be directed. XT, you don't need to be directing it. XT finds its way as long as there is a way. Because as we know, at least about 70% of CTOs have microchannels. So you can explore those microchannels. Let me confirm it first where it is. Because sometimes you feel it is in Bennett. Come on, inject.
No.
So no, it is
That's
okay.
good.
I think it's
You're
in
in
the
a
diagonal.
diagonal. You're
branch,
good.
I think.
You're good.
I think it is in the diagonal. Now
Yep.
that's
No.
no. Just a sec. Cranial view, please.
So this will be interesting. Are you gonna?
So-
what will be your next step, Dr. Surya? What would
Yes.
you do?
So
Yes,
whether you
yes.
go ahead with a parallel wire with a dual lumen catheter, that's ideal not to have subintimal for the two
what
lumen
type
of the
of a
main
vessel?
LED.
It's a septal or a diagonal, but it's in a vessel, isn't it?
It's a vessel, obviously.
Yeah,
It's
you're
in
in
a
a
vessel.
vessel.
Yes, if it's a Gaia, you can redirect nicely,
in
but the
some
filter
vessel.
XT is redirecting one-to-one torque is not there. So keep the wire there, take a dual lumen, that is safe and force.
Right injection, please. But which way is it going?
We change the view.
Can we get another angle?
Where is it going? No, because if it is in a lumen, then it will move
You
forward.
feel any resistance? Usually this
Wherever
jacket,
it is.
polymer jacket, you don't feel anything until you
I'm
go long
not
distance.
feeling. Oh no, I don't know whether I'm correct.
Ectopics are there.
I'm not
Yeah.
too sure whether I'm correct.
So you
There's
might not
ectopic.
be in a great
Come
place
on, right
right
injection,
now, so.
please. No, I don't think it is correct.
Yep.
I don't think
So
it is
I
correct.
think you keep the wire there.
I
The
don't
next
think
plan
it's
is
correct.
use a dual lumen catheter and take the parallel wire, or what is
So-
the
That's
so
the ideal thing.
Dr.
to-
Goel,
Yes,
do you want to
yes,
tell
I
us what
think
you're going to
that's
do?
what I'll
Because
do.
we're going to switch to the other lab shortly. What would be
I
your
think
next step?
I will do a parallel wire.
And you're going
I
to
think
do
my
it with the
next
dual
step would
lumen
be a parallel
catheter?
wire as of now.
Are you
Yeah,
going to
yeah,
use a
with the
dual lumen
crusade.
catheter for that?
And yes, I'm going to use a dual lumen catheter for that. Okay?
All right.
And
So
and let me see.
we'll join
Okay,
you shortly,
can
yeah?
Come back, I'll. Okay, okay.
Dr. Goel, we're back with you.
Yeah, just a sec.
Sure.
मुझे वो दिखाओ.
I think we change it to Gaia something because it's redirecting the
Yeah.
wire with one-to-one torque is important here.
Dr. Goel, Dr. Kamal Sharma, are you any thoughts on imaging this?
Just a sec.
He just wanted us to give a minute for him to work, and then he said he would
Right,
tell us
right
what has gone
injection,
on.
please.
Okay.
You see, I'm trying to redirect it.
What wire do you have?
Gaia 2.
You have a Gaia second, all right?
And
Okay.
you, please.
So did you do parallel wire at all, or did you just
नहीं.
switch to another wire?
Maybe one
No,
more
I
caudal
did
view
not
also
do
you take,
parallel
then
wire
you
Sure,
find
sure,
out
sure.
for caudal views.
So we'll let Dr. Goel work in peace. Guys, like anyone on the panel have any suggestions? What would you do in the situation?
No, he has to take a dual lumen catheter, you know.
Yeah.
Yeah, I think Dr. Goel, when we last left you, you were suggesting to use a double lumen catheter, right?
Yeah, I think I need to. I'll use a double lumen. Actually, I was trying to redirect it.
Okay.
But I don't think it is correct. Because initially when I was trying to get the double lumen in,
Right.
my guiding came out. So then I had to rewire it as such. So that is why I went into this.
No, whenever you
So
want to
I'll
take
leave it
parallel
here
lumen,
and
is it
do a
always
double lumen.
mandatory to take
Okay.
a double lumen catheter, or you can go
No.
directly?
No,
Parallel,
you
parallel.
can use
No, it's
parallel
just-
wire in different
No, you
technique,
have to
another
do a
micro
double lumen.
catheter and do it.
It's just generally it's just more convenient.
No,
to,
but,
to,
That
use
time
it
he's
as
in a
double lumen
branch,
is
so
just-
we suggested that.
Sorry. Dr. Goel, Dr. Dal wants to see a caudal view.
Yeah, I am.
I also suggest take a
just
caudal
a sec.
view.
Just a sec. Let me get the dual lumen in first.
Sure.
Then I'll show you.
Actually, we can say this parallel wire in three ways. One, you can take two wires.
Aage?
Otherwise, you can take seesaw technique
Okay.
with the two microcatheters,
Trap.
and you can take dual lumen catheter and
And
take
do
two
a
wires.
CSI exactly.
Trap.
So
Okay. So I take this out.
the good part in this case is
You've
that
trapped
again
it.
he has a lot of options,
I'll
right? I
take
mean,
this
you know, if
out.
this doesn't work, he doesn't have to get stuck here. I
Okay.
mean, he can try parallel wire, he can try ADR, he can go retrograde. You got a lot of options in this case.
Yeah, if parallel wire also doesn't work, then I'll do ADR.
Perfect.
Okay.
Actually, I don't know. Both the cases are of similar type and showing excellent techniques.
Exactly, Dr. Pratap.
Fix.
This was a non-dominant RCA, and you want to choose retrograde if you want to go through this circumflex collaterals, or what? How do you?
I mean, if you go retrograde, that's probably what I would do because it's much safer to
Detrap.
go via a septal and do it rather than go through that conus branch, and that's a
The
high
conus,
risk one. You
conus
shouldn't do
main
it.
thing is the spasm. You have to be very careful in dealing the
This
micro
is the
catheter
You have
passage
septals.
and all conus.
Use the septal.
Coming.
roller. As a last resort,
Just hold on.
use
I
conus.
won't worry. Okay. Here.
Agreed. So is that a crusade that you're advancing right now?
Actually, the guiding is not in a good shape. That is
Yeah.
the problem. My problem is the guiding. You know,
Right, right.
test karo.
So guys, again, for those that are starting to do CTOs, don't get frustrated.
Okay.
Dr. Goel is a super experienced operator. You see that, I mean, you have to deal with all of this, right? I mean, guide issues, backup, and then you have to figure out if this doesn't work, what's the next step that he's going to do, right? Now, once he got the guide in a little better, you can see that the
Okay,
dual
right
lumen catheter has
injection,
been
please.
advanced. And what's the next wire that you're going to use, Dr. Goel?
All right, let us see that. Give me a conquest.
So, Dr.
Conquest.
Pratap, do let us know when we are delaying the next session too much. So, I would. Can we stay with them? We started a little late. Can we stay
No,
with them?
you can
for a
actually
little bit
stay
longer?
up to 3:15. Exact 3:15 you have to go.
Okay.
3:15 actually we'll have the lectures, and we will be seeing the live case, what is happening there.
After that?
But
too?
3:15
Okay,
and
yeah.
then
Yes.
after
Perfect,
1 hour
perfect.
we have another
Very
4 live
short
cases
tip for
coming
the
up.
conquest.
Super.
When the wire is not progressing, what are the options, Dr. Arun? At this stage, like it looks like a simple CTO for a very,
Okay. Very short.
seasoned operator, but it is troubling. So,
Okay.
what could be the chance that the wire not progression? Is it lack of support?
I mean, the first
is
thing
of
that you-
calcium which is not seen properly in different views, or it is subintimal course from
See,
the
I mean,
Very
subintimal usually is a low resistance thing. So, I mean, once you are there,
Remove
it
the
usually
little.
advances more better. So, I mean, the first thing that I think what he's already done, I
there
think he
it
deep
comes.
throated the guide or
Okay.
increase your backup, right? I mean, if you think it's
There
just a
it is.
pushability problem,
Yeah.
that's purely what you
Give me
want to
the
do.
torso,
That's what I
please.
would start with. So that's one of the reasons why we typically choose a little bit more aggressive guides in CTOs, right? Again, I know this is kind of a setup question, and that's probably what you would do.
I
too.
don't, can you tell that because it is radial, it is
No,
the backup support is less? Do you tell radial is the problem, or it is?
I don't think so. I mean, it depends on how well the guide sits, right? I mean, I think he has a 7 French anyways.
The guide sitting in actually in a radial, I know you have less. I don't know. I'm not a radial operator.
Yeah, procedurals, I go femoral, man. I'm old school that way, but like again.
I think you have to use a long
This
sheets.
is a UP, I think. Now, what is the next aggressive guide you take?
Right, please. Right, come on.
Guide extension cap.
Guide extension. That's what guide extension will be.
But now the question is, we don't know if it's truly a, I think it's penetrating and going down. He just, with the Conquest Pro, I think
looks
he
like
should be
I think it is not like that. Actually, he's just reaching.
Now
that
it
is the
looks
situation
like,
where all the cardiologists fail
close to
in
the
use.
Same track.
Just reach, and then you cannot. You will be tempted to do much more during that
Right.
activity.
That's why you are suggesting a caudal view also in this case.
Yeah, but looks like he's just gotten somewhere. That's a Conquest Pro, Dr. Goel? Okay.
Yes.
He's there somewhere.
Check.
PVCs.
Check.
You have a run. Just be careful.
Right, please.
Yep.
No.
No.
Okay.
Still here also go for a parallel Y, I
This
suggest.
is a little
Which is what he's trying to
long
do
process,
right now,
huh?
right? Yeah.
There are already 2 wires.
But there is a technique by Goel itself. He actually have an orthogonal projection and see the
Exactly
wire.
what I will
Actually,
do
it's
is
only Goel actually introduced the technique to India,
will
even though Kamura
use
does in
this
US, Japan.
position as the main wire.
Yeah.
Yeah, the 3D wiring.
Okay. I need a trapping. I'll get the this thing out.
Sure.
Use this as the main wire and do crochet again. Do a parallel once again.
So, Dr. Goel, we're going to stay with you for another
Trap.
10 minutes or so, and then we're going to... do you want to switch and come back?
Long. Trap.
Please switch over to Werner and see 3 minutes or 4 minutes and come back to
back
Goel,
here.
another 5 minutes, and then we'll
Perfect.
wind up the session and go to the next lecture session.
Sounds like a plan. Hey, we'll let you work in peace for a few minutes. All right. Let's switch to Dr. Werner's lab and see where he is.
Actually, after the lecture also, we can come back and see what has
Exactly.
happened.
Like, we can catch
Please,
it at the
please.
tail end, so no pressure from our side.
There?
Come on.
Kissing, you go the 1:1 dilatation or what? Lesser size?
इसमें तो ठीक
Dr. Goel, we're back with you.
Kissing 1:1 or circ size or what is or lesser size? Kissing, if you want to do LCX, you take 1:1 balloon or you go lesser size?
Arun, which wire?
Okay,
Just ask the wire.
Not much disease in the circle.
Dr. Goel, is it still the the Conquest
Right
Pro, or what
injection, please.
wire do you have? You want to just... We had just joined you for a few minutes, and then we'll... It looks like you're across, yeah? Dr. Goel, can you hear us?
Yeah. Yes. You see,
Great job. Fantastic, Dr. Goel. Looks like you're in.
yeah. So I use the
image
parallel
quality is
wire twice.
Yeah.
Like
Do
the
you-
second wire also, the Conquest was also wrong.
Can you go
So
back
then
and
I
show us what you did,
used-
if it's okay?
I pulled out the first wire, used that Conquest as the main wire to set up parallel wire, and then used a Gaia 3. And actually the 3D wiring that I keep talking about, it's nothing more than a concept, to handle wires. So I use that also in between, trying to see where exactly I am in space and how to get back. You understand? Otherwise, you use your wits, especially if you are using single plane. If you're biplane, you are much better. So
Dr.
this is
Goel,
where
can
I
you
have
go
reached.
back
I
and show
feel
us what
it
you
is
did?
probably inside. Let me just do a little more. Yeah.
Yeah. Thank you.
Right injection, please. Now you see, this is the importance of that right, the contralateral. I don't know, it should move faster, no?
Yeah.
Right, come on. No, it is in, I think. It is in. Huh? What do you say? So all these collaterals get lost, when dissections happen, and that's the importance of always having a contralateral injection.
How does the wire feel? Like, I mean, if you are in the lumen, this should be like a really low resistance event, right? I mean, I don't like how the tip of the wire is, but I can't feel it though.
I see some haziness distal to the tip of the wire.
No,
The
but that
imaging
looks,
is
that
not
looks
that
like it's moving
perfect to see.
pretty.
Right injection, please.
No, you have to be cautious in pushing this wire.
I think
You
it
could
is
be
okay.
subintimal.
It's
Yeah,
subintimal because you see once you the imaging particularly very hazy there, not able to pinpoint where exactly your wire is.
Since we are very near
Right
the
injection, please.
lumen and in the architecture of the vessel, isn't it a good time to switch?
Well,
to
I am in, I
invaluable?
think.
It looks like you're in. Okay.
I don't know where you are.
But we don't
the
know
guys.
how much is subintimal and how much is in, but
We
looks
are
like
in
the
the
distal
hall,
wire
you
is
are in the vessel.
Yeah,
now
it's in.
now it looks
Good.
So no CTO is easy.
Yep.
You see,
No second CTO
no
is
CTO is easy.
equivalent to the
CTO
first
is
CTO.
CTO.
That is what you said. A CTO is a CTO.
Yes.
We have to go
अब देखा
to the
कितना-
1 minute.
Dr. Goel, we're going to stay with you for a minute.
It looks like
Thank
a
you
cake
so
walk.
much.
Yeah. Actually, I have crossed it successfully.
Yes.
Just show the right injection, please. Come on. So you see that?
Yep.
And this is Gaia 3. And what I was trying to tell my colleagues here, no CTO is easy. You know, it looked like a taper tip and everything, but you know, no CTO is easy. Every CTO you have to take full precautions, full preparations, and then do it. And that's the importance of the now you see I can only see it through contralateral. Antegrade will not show it at all. Right?
And we are all in agreement.
So I don't know what time it is. So I think rest we will do
you can do
behind the
offline.
camera.
Yeah.
Okay?
Thank you so much, Dr. Goel, for sharing
So
this
I
case
take this
with
out?
us.
Thank
You
you,
wanna
Dr.
summarize
Goel,
it?
for the excellent job done. Thank
Dr.
you.
Surya, do you want to summarize the case?
No, it's it's a lesson that looks like a simple CTO, tapering tip, and middle lady. They're all favorable points, good collateralized, good sized distal lady. But you see, the polymer jacket wire slipped, and that's a tactile feeling is not there. One of the disadvantage that went into a branch or a false lumen. The next option is going for a parallel wire by different methods, as Dr. Pratap said, as a Goel lumen or a seesaw technique or another tough wire. So the wire of choice is the Gaia wires in this case, but escalation of wires to conquest has to be done. Maybe there's a subintimal or the calcium is there, which is not seen on the angiogram. And different views of 3D wiring, I always say it's not of mathematics. It's like change your views and adjust your tip penetration of the distal cap. This is just 3D wiring, they named it. So that's very important in this case. Don't go by one view and just it is going smoothly, you will end up in false lumens. Thank you.
Thank you, chairpersons, Dr. Surya Prakash, Arun, and Urmil, and all other people. And we will wind up the session. And wonderful 2 cases we have seen, and both the CTOs are crossed. That is the beauty of the cases.